Medurstand, Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today we are going to talk about arterial blood gases. We have already covered pulmonary function tests, as this is the part 2 of tests which are done in various respiratory diseases. In fact, arterial blood gas has got much broader application, as I will shortly display. Now, these are some of the indications. The actual list may be longer, but almost all respiratory diseases, when patient is critically ill, it may be a severe attack of asthma, it may be COPD, it may be respiratory failure, it may be some poisoning due to which patient has got respiratory depression, or any acid-base abnormality. In acid-base abnormality, we measure blood gases, and one of the thing which we measure is oxygen, carbon dioxide, but we also measure various electrolytes. And then intensive care setting. I think anybody who is admitted to intensive care setting, it may be a case of burns, may be a case of trauma, it may be a case of shock or any serious illness. Anybody who is admitted to intensive care setting, I think, needs blood gases analysis. Then ventilator setting, if somebody is on ventilator, of course we need to do the blood gases frequently to adjust the setting of the ventilator. So as I said, actually the list is longer. You can imagine anybody who is critically ill would benefit from arterial blood gases. Now this is the technique. First of all, you must have proper equipment or a proper kit. This is the contents of a kit which has got everything. This is a special syringe which is required to collect the blood, and then we have the sterilizer and the needles and everything. And perform Allen test. What is Allen test? You actually simultaneously press both radial and ulnar arteries, and you know their anatomical location. And when you do that, and then you ask the patient to clench his fist 2 to 3 times, and that would actually all the venous blood will be pumped out, and when patient opens his hand, it would be blanched, so it would look very, very pale. So then you release ulnar artery hand, and then you repeat the test, and you repeat on the radial artery. And this is actually to make sure, and after you release the vessel, it should become reddish because blood comes back into the hand circulation. So you actually make sure that both the arteries are patent. Our main circulation of the hand is from the ulnar artery, that is dominant artery. So, and radial artery is superficial, that is usually used to draw blood for arterial blood gases. And because the predominant artery is ulnar, so I think theoretically it is acceptable to take the risk of radial artery thrombosis. That is actually one of the complications of arterial blood gases. So if both arteries are patent, it would be safe to do radial puncture. If that is not true, then you may try some other vessel. Sterilize and anesthetize the site and puncture radial artery from. You need to actually learn the technique. I will not be able to go into the detail because I am going to focus on analysis of arterial blood gas. Seal the syringe and send it to the lab immediately, because you know atmospheric air has got lot of oxygen and very little carbon dioxide. So if that gets mixed into that, oxygen level will increase and carbon dioxide level will reduce, and then all the derived values will also be affected. So the blood gas analysis would not only become unreliable, it would be actually misleading. So you must seal it. It is usually sealed with wax. This needle is usually sealed with wax immediately before we send the sample to the laboratory. Many times these blood gas analyzers are present within the intensive care setting. So even then I think you need to apply the soap here, wax here. Venous blood gases may be acceptable in some situation. Now what is the relevance? Arterial puncture is always difficult, and arteries are much fewer than veins. So venous puncture is much easier. In some cases, venous puncture may be as good as arterial puncture, particularly in metabolic diseases. Like it is recommended that in diabetic ketoacidosis, you can actually do the venous blood gases rather than arterial blood gases. There may be little difference. I think it is recommended that the first time you do both arterial blood gases and venous blood gases, and then you will know the difference, and then accordingly you repeat the venous blood gases. If somebody is on ventilator and somebody is on oxygen therapy, then I think arterial blood gases are essential. But in metabolic disorder, venous blood gases may be acceptable. Parameters. Now, what are measured? I think I will explain pH. It has got no units actually. It is just a number. Normal value is from 7.35 to 7.45. And you know, pH is one of those parameters which is controlled very tightly. Even slight difference means a lot of problem. So if it is less than 7.35, it is called acidosis, and if it is more than 7.45, it is called alkalosis. Now this is actually in clinical context, and if you go by chemistry, as somebody who has 7.3, he will be still acidic, alkalotic, because any pH more than 7 is alkaline. But anything below this physiological range is called acidosis. Now, if you do venous blood gases, because venous blood gas has got some lactate added to it, and that is an acid. So venous blood gases and the oxygen is extracted, carbon dioxide is added. So venous blood gas is typically pH is 7.31 to 7.41. All right, so this is the range. PaO2, this is partial pressure of oxygen in arterial blood, and the range is 75 to 100. Healthy people would have their PaO2 close to 100. Then PaCO2 is partial pressure of carbon dioxide in arterial blood, and this should be between 35 to 45 millimeter of mercury. Any rise would mean respiratory insufficiency, and any reduction would mean that patient is hyperventilating. So these three are directly measured values with the substance specific probes which are fitted on the machine. There are many other values which are derived from these. HCO3, which is bicarb, and the value should be 22 to 26 milliequivalents per liter. Then base excess. Base excess is actually, I think, the conversion of this acid and base into this concept. Normally we have a certain level of base excess. If it is more than that, that would mean alkalosis, and if it is less than that, it would mean acidosis. TCO2 is actually total carbon dioxide, and which is the same as total bicarb. SpO2, this is the saturation. Now this one is partial pressure, which is actually more important. This is saturation. What percentage of hemoglobin is saturated with oxygen? This does not measure the total amount of oxygen. This only measures the percentage of hemoglobin that is oxygenated. Now this is normally 94 to 100%. I think I have seen that mostly it is 99, not even 100%. Now, you know, this concept, arterial oxygen and carbon dioxide tension, partial pressure is also called tension. This actually refers to the soluble form of carbon dioxide and oxygen, not the one which is bound to hemoglobin. So this is very important concept. This measure the soluble form of oxygen and carbon dioxide. This measure the percentage of hemoglobin that is bound with oxygen. So both have their own roles in interpretation of various disorders. In some additional machines, some newer machines, they measure additional parameters like HB is measured and electrolytes, sodium, potassium, chloride, bicarb is measured, and they can also measure anion gaps. So the modern machine, if you're using some modern machine, you would have more parameters because all these things are normally measured from the venous blood, but they can be measured from the arterial blood also. Now, this is what I described as three-step approach. I think you need to learn this three-step approach, and only then you can make some sense of this complex blood test. First is you should be able to figure out the primary abnormality. Now, that means you should be able to figure out if it is acidosis or alkalosis. This can be determined by the pH alone. Then you have to figure out if the disorder is primarily respiratory or metabolic. This would require little expertise, and which I'm going to tell you how. Then whenever there is a primary disorder, there is actually compensation. A primary respiratory disorder will be adjusted by metabolic changes, and a primary metabolic disorder will be compensated by respiratory changes. Now, this is actually nature's attempt to minimize the primary abnormalities. So, uncompensated or versus compensated. If there is acute insult, it is likely to be uncompensated, and any chronic insult will be compensated. So, we will see if the primary abnormality has some compensation or not. And third is the measurement of anion gap, and this would be particularly helpful if from this disorder we have figured out that patient has got metabolic acidosis. Metabolic acidosis is of two types, one with the normal anion gap and the second one is widened anion gap. So we will discuss that also. So you should master these three steps. In the first step, you should be able to figure out the primary abnormality, whether the problem is acidosis or alkalosis, whether the problem is respiratory or metabolic. So most of the job is done here. Then you see if there is any compensation, and that will tell you if the disorder is acute or chronic, and if the compensatory mechanism is intact or not. And the third one is anion gap. This will the further refinement. If patient has got metabolic acidosis, then you will know which type of metabolic acidosis, and then we can, with further tests, we can reach the correct diagnosis. Now with an exercise, we are going to repeat the same. This is the exercise. Now these are the three steps. First question we answer is it acidosis or alkalosis? Then we want to know if it is metabolic or respiratory. And third one, with or without anion gap. Okay, so these are the three steps. Let's do the first one. First of all, I think this is extremely important when you read the blood gas report. The first parameter given is pH, and I think you must always first see the pH. pH will tell you whether or not patient has got a respiratory, or whether or not patient has got acidosis or alkalosis. Okay, you know, even if there is compensation cannot overcorrect the primary abnormality. If primary problem is acidosis, even after compensation, pH will be acidic. If primary problem is alkalosis, even after compensation, pH will be alkalotic. So first of all, see the pH. You can only overcorrect by medication, but the nature's mechanism, compensatory mechanism, will not overcorrect. So first of all, see the pH. So pH could be less than 7.35, or pH could be more than 7.45, or of course it could be normal. If it is normal, then pH is normal. If it is less than 7.35, it is acidosis, and if it is more than 7.45, it is alkalosis. I guess first step is easy. All right, so this much is easy. But then if patient has got acidosis, then you have to figure out if it is metabolic acidosis or a respiratory acidosis. Metabolic acidosis means that there is some acidic material present in the blood, which could be endogenous or which could be exogenous, which we'll discuss later. Respiratory acidosis basically means accumulation of carbon dioxide, because carbon dioxide is an acid. So accumulation of carbon dioxide, which obviously means respiratory insufficiency, that will cause respiratory acidosis. If it is alkalosis, it could be metabolic alkalosis that you can do by that can happen when there is some alkali deposition in the body or acid loss, or it could be respiratory alkalosis, and that can happen when you hyperventilate. When you hyperventilate, you wash out your carbon dioxide. When you wash out your carbon dioxide, the net base is in excess, so you develop alkalosis. So this is the second step. And in the third step, I think that is applicable here only. You do anion gap analysis and see, and you can have a disorder with wide anion gap, and you can have a disorder with narrow anion gap. Actually, I have another video which will explain these concepts. So we will actually practice up to this point in this video. For the test, if somebody has got wide anion gap, there are actually multiple possibilities, and depending upon the clinical scenario, you will do further test. So let's do the exercise now. I think you have now some idea, and you can, I think, be able to do. You may be able to do this exercise now. Now, on every slide, I have shown you the normal values, normal range of pH, normal range of PaCO2, and normal range of bicarb. Oxygen is not given here because we are actually discussing acid-base abnormalities. All right. So this is the case. I will give you a few seconds to figure out. pH is 7.26 and PaCO2 is 51 millimeter of mercury. HCO3 is 25 millimoles per liter. First thing first, you note the pH. Is it acidic or alkalotic in clinical context? It is less than 7.35, so it is acidosis. So we have figured out one thing, it is acidosis. Then go to these two parameters. PaCO2 is acid and it is in excess. And bicarb is an alkali, and that is within the normal range. Bicarb is within the normal range in this case. Okay, so 22 to 26 is normal. So what do you think? What is the diagnosis? It is acidosis, respiratory. Do you agree with me? So it is respiratory acidosis without any compensation. Perhaps it is an acute phenomenon, acute respiratory insufficiency. Now let's do another exercise. Somebody has pH of 7.56 and PaCO2 of 21 millimeter of mercury and HCO3 25 millimoles per liter. So what is the primary disorder? Is it alkalosis or acidosis? It is more than 7.45, so it is alkalosis. Now what is PaCO2 21? Is it normal or above normal or below normal? It is below normal because normal should be 35 to 45. So carbon dioxide is below normal and bicarb is within normal limits. So what is the diagnosis? It is alkalosis and it is related to carbon dioxide washout. So it is respiratory alkalosis. So somebody who is hyperventilating intentionally, or patient is on ventilator, or there are other reasons actually. So this condition would be called respiratory alkalosis, most probably acute one because there is no compensation here. I will explain the concept of compensation later. Here you just see the primary abnormality. So I think this was also easy. Respiratory alkalosis. Let's take another example. pH of 7.26 and PaCO2 38 and HCO3 bicarb is 17 milliequivalents per liter. I think if you follow the sequence we have already covered respiratory acidosis and respiratory alkalosis, you should be able to figure out what should be next, but still this is acidic, okay? It is less than 7.35, so it is acidosis. Which type? Carbon dioxide is an acid. It is not, it is with the normal limits. So carbon dioxide cannot be responsible for this acidosis. It is this loss of bicarb. Bicarb is alkali. Patient has some disorder where the patient is losing bicarb. So because of low bicarb, patient has got acidosis. Okay. So the diagnosis is metabolic acidosis. There are actually several conditions where could be metabolic acidosis that will be covered in separate modules. But here you should know, you should be able to figure out this diagnosis of metabolic acidosis from this arterial blood gases. Let's take another example. pH of 7.54, PaCO2 of 48 and HCO3 is 37. pH is 7.56. Okay, that means alkalosis. PaCO2 48, it is slightly high, but this CO2 cannot cause alkalosis, it is acid. So let's go here. Bicarb is increased 37 and bicarb is alkali. So I think this excess of bicarb is perhaps responsible for alkalotic pH. So it is metabolic alkalosis. Metabolic, why? Because bicarb is excess. Alkalosis because pH is alkaline. Now have you noticed this carbon dioxide is slightly increased? Actually, whenever there is metabolic insult, respiratory compensation starts immediately. So I think it is really very hard to have a patient of pure metabolic alkalosis without even slightest respiratory compensation. That is possible in respiratory disorders because metabolic compensation takes time. I hope I'm clear on what I said. Now, we will now discuss the concept of compensation and then we'll take up some more cases. What is compensation? Carbon dioxide and bicarb act as buffer pair and their ratio determines the pH. There are many other acids and bases in the body, but carbon dioxide and bicarb, they have the primary responsibility of maintaining pH in the body. And nature has made a very good system. Carbon dioxide is acid, bicarb is alkali, both are to be in a normal ratio. If one increases, the other also increases to maintain the ratio and to maintain the pH. If one is deranged in either direction, the other will move in the same direction. If carbon dioxide is increased, bicarb will be retained with time, and if carbon dioxide is reduced, bicarb will also be washed out from the kidneys. Now, in the other way, if bicarb is increased, carbon dioxide will also be increased by reducing ventilation, and if bicarb is reduced, then carbon dioxide will also be reduced accordingly. So whichever way bicarb goes, carbon dioxide will also go the same direction by nature's compensatory mechanism. Compensatory mechanism fails to completely normalize pH. Now, a compensatory mechanism can be called 100% efficient if it normalizes pH. So these compensatory mechanisms are not actually 100% efficient. They minimize the change but are usually unable to correct it completely. Now what is the implication? Implication is despite compensation, the final pH will still be the same as the original abnormality. So I think this is important. And as I said earlier, you can overcorrect by medication. But actually with the nature's compensatory mechanism, it will be only partial or near complete compensation. CO2 response is the fast, but HCO3 response is slow. Because CO2 response, all you need is to hyperventilate or slow down ventilation, and that can happen over seconds. Whereas bicarb generation or bicarb removal takes time, and this is done by kidneys, and it could take hours, days or weeks. So you may not have full compensation until several days have passed. So with these background concepts, let's now discuss it further. Now this is the example of compensation in respiratory disorders. Okay, so imagine primary problem relates to carbon dioxide. How will bicarb compensate for this? So imagine primary problem, there is increase in carbon dioxide. Okay, increase in carbon dioxide. That condition is called acute respiratory acidosis. Now, since bicarb is going to take time, there may be a situation you have just increased carbon dioxide, bicarb within normal limits. This was shown in an exercise earlier. Second example is chronic. If the time passes, due to chronic carbon dioxide retention, there will be retention of bicarb also. So bicarb level will also increase. So because of increased bicarb, you know now that this is chronic respiratory acidosis. Now I have tried to draw this arrow a little shorter than this, just to say that it has partly corrected the primary abnormality, but it still is acidotic. So you can differentiate acute respiratory acidosis from chronic respiratory acidosis from bicarb level. In acute respiratory acidosis, you will have just increased carbon dioxide, bicarb will be normal. In chronic respiratory acidosis, you will have increase in both. Now, in alkalosis, carbon dioxide may be washed out. If carbon dioxide is reduced, but bicarb is normal, this would be acute respiratory alkalosis. That means it is acute phenomenon. There is not yet any compensation by kidneys, because kidney compensation takes time. So in acute respiratory alkalosis, you will just have reduced carbon dioxide, bicarb will be normal. But as the condition becomes chronic, bicarb will also be removed from the body. The level will come down. So then you can tell that this is chronic respiratory alkalosis. So you can differentiate between primary and the acute and chronic respiratory disorder from the fact whether or not bicarb is increased or decreased. We are still continuing, and now we are going to take metabolic acidosis. Okay, in metabolic acidosis, primary abnormality relates to bicarb. So in alkalosis, bicarb is retained, bicarb level is increased. You've seen that almost immediately rise in carbon dioxide occurs because respiratory response compensation is very fast. So it is very difficult to have a condition where somebody has just elevated bicarb, because immediately carbon dioxide will also rise. So metabolic alkalosis, whether acute or chronic, will have both elevated bicarb and elevated carbon dioxide. In metabolic acidosis, bicarb is reduced and immediately carbon dioxide is reduced. So in acute or chronic metabolic acidosis, you will have reduced bicarb as well as carbon dioxide. And this has corrected the abnormality to a certain extent, but patient still has some acidosis. So based on these principles, you can figure out if there is compensation or not. I think the compensation would mean the disorder is chronic. Now let's do some more exercises. Exercise number 5. Somebody have pH of 7.29 and PaCO2 of 51 millimeter of mercury, and HCO3 is 47 millimoles per liter. What is the primary abnormality? Acidosis, right? And why acidosis? Because of increased carbon dioxide, because carbon dioxide is an acid. So this explains there is respiratory acidosis. Now let's see if there is compensation. If there is increased carbon dioxide, as a compensation, bicarb is also likely to increase, is also expected to increase, and that is exactly the case here. Bicarb is also increased. So this is respiratory acidosis with metabolic compensation. Alright, so respiratory acidosis, because primary abnormality is increase in CO2 resulting in acidosis, and as a compensation, as a compensatory mechanism, with time bicarb has also increased. Since this happens with time, so that is why I say it is compensation, and it is most probably a chronic disorder, slightly chronic disorder. Exercise number 6, pH 7.51 and PaCO2 51, HCO3 42. What is the primary problem? Acidosis or alkalosis? It is alkalosis. And can this increase CO2 explain this alkalosis? No, CO2 is an acid. Can this increase bicarb explain alkalosis? Yes, it can. So it is probably metabolic alkalosis with respiratory compensation. Metabolic alkalosis with respiratory compensation. So you have figured out this condition also. Now we have covered all these metabolic situations, and let me give you a summary now. Now, after discussing various case scenarios, this is actually a summary and differential diagnosis of various acid-base abnormalities. The first step is acidosis. We have to figure out if it is acidosis or alkalosis. So pH less than 7.35 is acidosis, and pH more than 7.45 is alkalosis. In acidosis, we could have metabolic or respiratory acidosis, and similarly in alkalosis, we may have metabolic and respiratory alkalosis. Now I have listed the primary abnormality in red, and green is the compensatory mechanism. You will see both. When you see the report, you will see the both, but you have to figure out which one is the primary, which one is the compensatory. That you can figure out from the pH. So in metabolic acidosis, you have low bicarb and low carbon dioxide also. In respiratory acidosis, you have increased carbon dioxide and increased bicarb also. In metabolic alkalosis, you will have increased bicarb and increased carbon dioxide. And in respiratory alkalosis, you have reduced carbon dioxide and reduced bicarb. So I think there is an overlap. So you need to have the clinical context. I think you cannot interpret this unless you know the pH. So you must focus on these values after knowing whether patient is acidotic or alkalotic. Now these are some of the examples. Once we, I think from this side, respiratory alkalosis can occur in hyperventilation, and metabolic alkalosis can occur in Cushing syndrome and diuretics. Respiratory acidosis can occur in acute respiratory insufficiency, whatever cause, but metabolic acidosis could be due to various reasons, and some of them have no normal anion gap, like we lose bicarb from GIT, diarrhea and vomiting, or there could be wide anion gap due to accumulation of any of the unmeasured anions. This concept actually I'll explain in my next video, but just to complete this module, this can occur in diabetic ketoacidosis, lactic acidosis, renal failure, liver failure, and aspirin poisoning and other poisoning. So basic concept is that because of the accumulation of any of these acids, nature is trying to adjust the level of bicarb to make the balance between cations and anions equal. So I think this concept is complex one, and I have reserved one video for this. I'll see you there also. Now this is a disclaimer. Real life is much tougher than these case scenarios, because I gave you very typical easy case scenarios and they are easy to figure out. In real life, the situation is much more complex. Why so? Because of multiple comorbidities. Patient may have predominant respiratory disorder, but he or she may have additional complication like shock or hyperperfusion and things like that, additional metabolic issues. So you can have multiple acid-base disorders at one time. And number two, there is variable compensation. Everybody does not compensate as fully as was shown in the case scenarios. And then there could be effect of medication, because primary acidosis, if treated with too much alkali, then could actually result in alkalosis. The primary problem is still acidosis, but when you see the patient is alkalotic. So because of these situations, the real life, I think, is much tougher, and you need a lot of experience and a lot of expertise to be able to make correct diagnosis. I think in this situation, clinical context is extremely important. Summary: ABG understanding is extremely crucial for the understanding and management of all critical diseases, and the context must be considered as treatments and comorbidities have profound effect on blood gases. Thank you very much. This has been Professor Aziz-ur-Rehman, and this was a complex topic. I hope I was able to justify it, and I hope you have learned something out of it. And please keep exercising to learn more. And I really look forward to see you in my next video, which is again going to be on another aspect of respiratory functions. Thank you very much.